So from these particular sources they are coming. What are these particular veins? They are primitive veins penetrating through the septum transversum and eventually draining to the developing future heart, which is known as sinus venorum or sinus venosus. So this part of this particular of the hepatic sinusoids are derived of the breakage or transformation from this particular umbilical vein and this particular vitelline vein. Now, then we are left with this C element, the connective tissue. The septum transversum, which is a mesenchymal element, itself gives rise to this particular capsule of the liver. The capsules of the liver is covered with a capsule, we call them as Glissen's capsule. That particular capsule is derived of this particular mesenchymal element. That means it is coming off ST, the septum transversum, into which the liverwort grows. So this particular septum transversum gives rise to this particular capsules, other cells than the liver cells. Which are the other cells? The defense cells present in the liver, phagocytic cells. Other cells like hematopoietic cells, they are coming from this particular, the septum transversum source. They are mesodermal or mesenchymal in origin. So if you split that particular development of the liver, it is developed from the distal part of the foregut tube into the septum transversum, grows into and breaks down the content of this particular septum transversum itself. It breaks down the blood vessels to transform into hepatic sinusoids. It breaks down this particular septum transversum content into develop into this transform into some hepatic cells, which is non-parenchymal cells, non-hepatic cells, defense cells, structural cells, hematopoietic cells, etc., etc. And the hepatic parenchyma or liver cells itself develops from the hepatic bud. The same hepatic bud is developing from this particular outgrowth from this endodermal tube, which gradually grows into it and give rise to this particular parenchyma. Now, within this particular liver tissues or liver parenchyma, we have intrahepatic biliary channels. Those intrahepatic biliary channels also develops from this particular hepatic parenchyma, which is coming from this endodermal tube. So these liver cells, which is developing from this particular hepatic bud plus intrahepatic biliary system, the minute biliary channels into which this particular hepatic cells dumps these excretory products that grows into. So this is the whole transformation or whole formations of the liver. So once again, we have the liver which grows at a particular age, starts at the developing at 3rd week of life to 5th week of life to 6th week of life. By that time, liver grows. So between 3rd week of life to 6th week of life, spanning between these 3 weeks, the liver grows. So where from the liver is growing? The foregut tube, the primitive foregut tube. Which part of the foregut tube? Lower part. That means we call them as the distal part of the foregut tube. Now what happens here in the distal part of the foregut tube? We had an out pouch. We call them as diverticulum. And that diverticulum we call them as bud. By the blossom bud, B-U-D. That particular bud grows into a substance. Which substance? A mesenchymal element, which is present between the growing heart and the hepatic and the abdominal cavity. We call this particular growing tissue or mesenchymal tissue as septum transversum. So into this particular mesenchymal element or septum transversum, this particular hepatic bud grows and transforms slowly. It transforms this septum transversum in the form of whatever the blood vessel that was penetrating through, especially these vitelline veins and the umbilical veins, they are split into and utilized by the liver to make or transform into hepatic sinusoids or hepatic channels. They are coming from these particular veins which is penetrating the septum transversum. Where from the hepatic cells are coming? The cells are coming from the endodermal tube. That means coming from the bud. Where from the other cells than non-hepatic cells coming from? They are coming from the septum transversum, the capsule. The other non-hepatic cells, they are coming from these different cells or the different entities. So this is about this particular liver which was growing, and it is a big organ to grow. As we have seen, this is the largest organ in the abdominal cavity. Once you open up this abdominal cavity, this is visible. So this is how this particular liver grows. Now from here, taking from the same source, we are going to talk about the development of the gallbladder. So we have started with this particular entity, which is the C line, which is the connections between the growing hepatic bud and the endodermal tube. This particular tube, we call this as tube, which is marked with the C out here. So this particular connection or the channel, which is lying between this foregut tube and the liver bud, we call this as a primitive bile duct. Now this particular primitive bile duct, which is forming the part of the bile duct which is outside the liver, we call them as extrahepatic biliary channels. So from these extrahepatic biliary channels, there is again formations of a bud or projection. You see this is coming out. So from this particular tube, which is a connection channel, a growth is coming out as a bud or a diverticulum. We call this diverticulum as cystic diverticulum. Now this cystic diverticulum elongates. Now this cystic diverticulum, as it elongating, it has two parts. So this particular cystic diverticulum, which was growing like this, has a two part, proximal part and the distal part. This is the distal part, away part. This is the proximal part. This distal part grows to give rise to this particular pear-shaped organ, the gallbladder. The proximal part, which is present in here, forms this duct, which is known as cystic duct. So this particular cystic duct, along with this particular gallbladder, they are sourced from this particular channel, which is communicating between them, which is growing as the outpouch, which is known as cystic diverticulum, which is growing into it. So this is how the gallbladder, the biliary passage, intrahepatic and the extrahepatic biliary system develops. Now this is a complex phenomenon. We have a sequence of the genetic signal and we have a complex sequence of this neurotransmitter working in here. So this particular release of the neurotransmitter, release of this particular sequence of the things which are happening may not happen in a sequence the way we want it. And if it is not sequential, we get a disease or anomalies around this particular liver and the gallbladder region, which is quite common. So we get a number of the errors of this particular liver and the gallbladder anomalies. We may have this particular abnormality like absent of the liver. That means the hepatic bud is not formed and liver is not formed. The cystic diverticulum is not formed. The gallbladder and the system is not formed. So this is a phenomenon if it is happening there. Same thing happens over here. We have this gallbladder which is growing into here. Now this particular gallbladder anomaly commonly happen. This particular gallbladder which is developing from the cystic diverticulum is sucked into this liver bud. And as the liver bud is growing, this cystic diverticulum is growing within this particular liver bud. And resulting in formation of the gallbladder is incorporated within this particular liver substance, which leads to a phenomenon we call them as intrahepatic gallbladder. Sometimes what happens, this particular liver bud and this particular cystic bud grows at a different pace. If it is growing at a different pace, this particular cystic diverticulum may grow differently or may be separated out of this particular liver under surface. So that leads to the formation of this particular phenomenon. We call them as a wandering gallbladder or mobile gallbladder. So gallbladder is loosely hanging on the transverse colon if it is cannot keep the pace of the liver bud growing. So we may have this particular floating gallbladder and the intrahepatic gallbladder depending on if you have error on the cystic diverticulum formation and the transformation. Similar to that, we have this particular channel. We call them as like a duct system error, which is also common. So we may have the biliary atresia. That means this particular channel within this particular cystic duct or this particular intrahepatic, extrahepatic channels may be obliterated, may not be formed, may not be canalized. That means leading to this particular atresia. Atresia of these particular channels may be extrahepatic, maybe intrahepatic, maybe complete, maybe incomplete. So depending on how this particular channels or atresia of this particular gallbladder is happening, we may have a series of congenital errors of the biliary system. So this particular congenital errors of the biliary system, including the development of the liver, is an exam short note question. So common phenomenon which is involving this particular hepatic bud and the cystic diverticulum or cystic bud formation and the transformation, we have a number of these congenital diseases. So we have to know and write down this particular diseases, whatever it is happening congenitally, if you have the faulty development. So you do not have to explain a lot things about it. You just like give a picture and just explain the picture, that makes it all. So intrahepatic, extrahepatic biliary atresia, like this, giving a picture, that's an entity, that's a thing, right? So this entity is about this particular atresia of the biliary system and this particular errors of the liver or these hepatic tissue abnormalities may be there. So maybe we have this absent of the gallbladder, maybe we have the two gallbladders, if you have the two cystic diverticulum which is present. We may have this absence of the cystic duct, maybe just like this particular distal proximal part of this particular cystic diverticulum is not formed. So depending on this particular atresia and the gallbladder error, we get a number of these embryological developmental quotient based on these errors. Now moving from this gallbladder to this particular another organ which is also a foregut derivative, we call them as pancreas. Now we have learned about this gallbladder, we have learned about this particular hepatic development which is growing in phenomenon. Now another organ which is important out here, we call this as a pancreas. Now like this particular gallbladder, like this particular hepatic, this pancreas also develops as an outpouch from the same primitive gut tube. So this particular diverticulum into which this particular pancreas develops from, we call them as a pancreatic bud. Now this particular pancreatic bud develops from this particular same distal part of the primitive foregut. Now as you can see, to start with, to develop with, the pancreas or pancreatic bud is two. So far we have seen the hepatic bud, the cystic diverticulum was single. Out here, in case of the pancreas, you can see in the picture, we have two developing pouch. One is on the ventral side, one is on the dorsal side. We have two colors used in it. But in adults or in reality, we see that the pancreas is single. So we have a single pancreas when to develop with in these adults. And then in developmentally, we are getting it two. Now, before we move into, we have to know or we have to understand the parts of the pancreas. So we have these four segments of the pancreas we know so far. One is towards the spleen end, one is to the duodenum end, right? So extending between this particular posterior abdominal wall from the mid side or close to midline to this particular extreme fag end. This end of the pancreas we call them as tail of the pancreas. Next, moving here, we have the body and we have the constriction part which is known as the head of the pancreas. No, we call them as neck of the pancreas, right? So we have this neck of pancreas over here. The important phenomenon taking place here is the formation of the portal vein, which we have learned yesterday. Now this is the head, and on the surface of the head we have a projection. We call them as uncinate process. Now this particular head, developmentally we split into two parts. So the lower portion of the head with the uncinate process is section 1, and the upper part of the head along with the neck and the body and tail we divide into part B. So I repeat, so we are talking about the development of the pancreas. We have seen this particular pancreas as an adult, we have these four parts: head, neck, body and the tail. Now whenever we are seeing that, we are retrospecting how this pancreas is formed. We are seeing this pancreas is coming from two projections. That particular two projections we call them as pancreatic bud. and two projection is on two other side. One is on the anterior side, one is on the posterior side. One is on the green line, a blue line, other is on the red line, right? A red shadow or red picture which you are seeing here. So this one, which is on the ventral side, and the red one is on the dorsal side. Am I right? So the blue line is the ventral side, the red one is dorsal side, back side, right? So this particular thing is growing on the ventral mesogastrium, and this one is growing on the dorsal mesogastrium. So initially to start with we have two, but in adult we have this particular single pancreas. So by any times or by any process of the developmental course, we have to join these two to make it one, right? Or else we'll be getting two pancreas. So that's what happens with this particular pancreas development. To start with, they have pancreas bud. We have two, dorsal pancreatic bud and the ventral pancreatic bud. So this particular dorsal pancreatic bud and the ventral pancreatic bud was present on two occasions. Now this particular dorsal pancreatic bud, which is present on this particular posterior side, and the ventral side we have this ventral pancreatic bud. This joins together to give rise a single pancreas. So this particular part, which is known as the ventral pancreatic bud, goes under and goes posterior to this particular dorsal pancreatic bud. So this one, which was present in the front side, switches back and below the posterior one. So this one moves back under and the posterior one and goes into it. Now why does it move and why does it go under to it? Is there any phenomenon which is basically initiating the movement of the ventral bud to move to the dorsal side? So we have a phenomenon we learned yesterday or previous class. This is what? Stomach. This is what? The future duodenum, which is going on. What happens with the stomach development? It rotates clockwise. When this particular stomach and this particular upper part of the duodenum rotates longitudinally, this particular ventral pancreatic bud, which switches also, goes posteriorly and goes under to this particular dorsal pancreatic bud. So with the subsequent time, we see that this particular ventral one going on the back side with the movement of this gut tube or of this stomach from the ventral side is moves to this particular back side. So this was in the front side, which you're seeing here, transforming into this with the time of these rotations of the stomach and the duodenum. So this ventral one, which was blue, which was initially at the front side, switches below and posterior to this particular dorsal pancreatic bud. And as the time progresses, these two joins with each other. The ventral pancreatic bud and the dorsal pancreatic bud joins with each other and makes a single pancreatic bud, and which eventually grows to adult form, whatever we are seeing here. Getting it what I'm trying to say? To start with, we had two pancreatic bud. With the movement of the stomach, this ventral one goes under and posterior to this particular dorsal one and switches with this, and then we get a single pancreatic bud which is growing on the posteriorly and growing into whole pancreas. Now whatever we have to understand what this particular ventral pancreatic bud grows into and what this dorsal pancreatic bud grows into. So that's why we have divided with this. So this section, which is known as lower half of head of pancreas plus uncinate process, which is shaded out here. So this is shaded out here. This lower half of the head and this uncinate process, they are coming from the ventral pancreatic bud. And rest of this pancreas, that means everything in the blue is coming from dorsal pancreatic bud. So this is how this pancreas develops into single pancreas from the two buds. So we have these two buds, ventral and a dorsal. The front one, the ventral one, with the rotations of the stomach and the duodenum, goes posterior, goes under, and switches or joins together to make this particular single pancreatic bud. Only this particular lower part of the head and uncinate process that develops from this particular blue shadow or blue element, which is a ventral one. This part only develops into head and this uncinate process, and rest is upper part of the head, neck, body, and the tail that develops from this red pancreatic bud, which is dorsal pancreatic bud. So this is how this organ, pancreas, develops into. Goes under and posterior. Now, samne asche na, it's remain, it is not changing the position. This one is switching and going under and posteriorly with the rotations of the stomach and this duodenum. When this particular stomach is rotating with this one is rotating like this with this clockwise direction and moving on the posteriorly and moving under to it. Once it grows under, it gets together, gets this particular end sticky, and then joins together and joins this particular whole pancreatic bud. So this is how we get this particular pancreatic bud, which is fused. So going under and below with these rotations of the stomach and rotations of this particular duodenum and giving rise to these particular parts of this particular bud. So this eventually transformation of this particular pancreatic bud, which is happening out here, which is taking place in here, is because of this particular rotations of the stomach and this pancreas. So this is how this pancreas is developed. Again, the pancreas, which you saying here, is a kind of developmental process. We see that how these things are coming. Now we have a number of things or number of error of the pancreas development error is happening. Now one of this particular pancreatic problem or this particular error of the pancreatic development is known as annular pancreas. So we have a developmental error which is commonly been tested in examination. We call them as annular pancreas. Now the annular pancreas is given as a short note, and we have to understand how this particular annular pancreas is happening. So what happens with the annular pancreas is that we have this particular duodenum which is going on, and an annular pancreas, we see that a pancreatic tissue which is encircling the duodenum. That means this pancreas is surrounded by, the duodenum is surrounded by throughout this particular circumference by some pancreatic tissue. And if you have a pancreatic tissue surrounding to this particular duodenum, it blocks this particular duodenum lumen or the cavity of the duodenum. So this annular pancreas is a developmental error or developmental formation. So for that reason, we have to go back to this particular pancreas development. So to start with, mention that we have two buds. One is this dorsal and one is this ventral pancreatic bud. So this ventral one was single and the dorsal was also single. So if we have any error, instead of single ventral pancreatic bud, we have a two or bifid or two ventral pancreatic bud. So we have, instead of one ventral pancreatic bud, by error, if you had by any chance two pancreatic bud ventrally placed, then what happens? One of this particular pancreatic bud, when this particular movement of the stomach taking place, rotates clockwise, other one is rotating anti-clockwise, and resulting in encircling this particular part of the duodenum which is growing into it, and covering this particular duodenum and growing eventually to this particular region. And from here to here to here, we get a pancreatic tissue surrounding this duodenum. And this phenomenon, we call them as annular pancreas. That means it is circumferentially covering it. So this is a short note, we get it in examination as an annular pancreas. So then, for example, if you are getting this particular exam question as annular pancreas, you have to say that how this particular annular pancreas is developing. So this annular pancreas is developing because of the faulty development of the ventral pancreatic bud. So ventral pancreatic bud, instead of one, we have two, or bifid, and with the rotation, this particular ventral pancreatic bud, one of them rotates clockwise, other one rotates anti-clockwise and encircle this particular second part of the duodenum and grows into. And as a result of this, the food matter, whichever is passing through the stomach through the duodenum, cannot pass through. So this particular patient, we have this particular obstructions of the passage. We call them as signs of intestinal obstructions. The kids who are born with this. So take the food matter, comes over here for a period of time and then throws out, vomits out. So this is the common presentations of this particular annular pancreas, which is happening if you have the faulty bifid ventral pancreatic bud. Now this ventral pancreatic bud or annular pancreas, I repeat, is your exam question. We ask questions about this particular annular pancreas as a short note. So you have to prepare this, explain this embryologically, giving a schematic diagram and the clinical presentations of why this particular patient have vomiting, which is happening because of this particular annular pancreas. So this is what we covered with this foregut tube. The important region about the foregut tube is that we have to know this development of the stomach. We have to know the rotations of the stomach. We have to know this rotation types, how the stomach is going on. We have to know the fate of the rotations of the stomach. What happens if you have rotations of the stomach? Then you have to know about this particular development of the liver. What are the different liver component tissues we have, and where from each of these component tissues structural different element of the liver tissues are coming into and develop into. We have these errors of the liver and the gallbladder development, which are commonly happening with this particular clinical errors, which is happening like a bile duct error or a gallbladder error or a hepatic tissue error if it is there. And then we have to know about this pancreas, how this pancreas develops from, and what are the parts of the pancreas bud to develop with, and what bud develops into which part of the pancreatic tissue in adult, etc., etc., and annular pancreas, which is a kind of like an error of the pancreatic bud development that you have to know. Now from here we're going to talk about this midgut, and a little bit about the midgut we have to just like brief through. Just like foregut tube we talked about, foregut develops from this part. This particular midgut also develops into this particular part. So it develops in the lower part of the duodenum, the upper part of the duodenum. We have this particular develop from the foregut tube, lower part of the duodenum, coils of the jejunum, ileum, cecum, appendix, ascending colon, and the 2/3 of this transverse colon is developing from this midgut tube. We learned about the blood supply of this GI system, like supramesenteric artery, inframesenteric artery, how much is supplied by the supramesenteric artery, how much is supplied by this inframesenteric artery, what is the transition line about this blood supply. So this basically explains why we have this supramesenteric artery supplies this particular area of the transverse colon, which is the anterior 2/3 or this particular proximal 2/3 of the transverse colon. So up to this much are the junctions of this particular proximal colon, which is like the proximal 2/3 and the distal 1/3, or the left 1/3 with the right 1/3 junction. Up to that, we have this part of the gut supplied by the supramesenteric artery. So this is the derivative that we have to know, where from this gut is developed. Now coming to short about this duodenum, we do not have to make these things complex about duodenum development. We have a duodenum, we split into 4 parts when we are starting this duodenum understanding in the gross. First part, second part, third part, and the fourth part. In embryology, it's not that complex. We divide this duodenum developmentally into 2 parts. A part above the origin or above the opening of the ampulla of Vater. What is ampulla of Vater? We have this particular ampulla of Vater, which is an opening where this particular pancreatic duct with this particular bile duct, which is coming here, which is known as cystic duct, drains into. So above the opening of this hepatopancreatic duct, we call them as ampulla of Vater, is developed from this foregut tube, and below that we develop from this cranialmost part of the hindgut tube. So this particular entity about this foregut tube, which is contributing to the upper half of the duodenum development, and this midgut tube, developing the lower part of the development of these duodenum, we have to know, and we have to know where the embryologically we have the border existing between these developmental aspects. We call this as an opening of the ampulla vater, which receives the opening of the two ducts, bile duct, which is coming here, which is known as common bile duct, and the pancreatic duct. So this particular part enters here, above here, develops from this foregut, below is coming from the hindgut tube. Rest part of this particular midgut, it develops from this particular tube. We call them as primary intestinal gut tube. In short, we call them as PIL. So primary intestinal loop. It looks like a U tube. Now this particular U tube, which you're seeing here, U-shaped, which is pierced by in its axis by this artery, which is known as superior mesenteric artery, which is framing here. This whole thing develops into the gut tube or the entire thing. So this particular gut tube eventually develops into everything, whatever the content we are coming from. Like it develops from this particular jejunum, the upper part of the ileum, the lower part of the ileum, cecum, appendix, transverse colon, ascending colon, transverse colon two-third. So everything in this particular development is coming from this primary intestinal tube, which this particular thing is coming from. So we'll continue about discussing this in the next class about this particular primary intestinal tube transformation and this particular primary intestinal tube transformation derivatives, whatever is coming from it.
Let's start. Salivary secretion is increased after the nerve to salivary gland is cut. কারো কোনো আইডিয়া আছে এটা নিয়ে কেন হচ্ছে? We might have a feel na যে nerve to salivary gland is cut, so saliva secretion should go down, but that's not happening. Why this is? What is the reason? বলো বলো, কারো কোনো আইডিয়া থাকলে বলো। লোকাল, জোরে বলবে। লোকাল, তাহলে এটা পরীক্ষা আসলে উল্টো পাল্টা লিখতে এতদিন। Definitely. Let's answer. এটার রিজন হচ্ছে denervation hypersensitivity. Denervation hypersensitivity. এই টার্মটা it is required. এটা দেখলেই most of the time আরো যা যা blah 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 লিখেছো তার মধ্যে denervation hypersensitivity if I see I will give 4 out of 5. Simple. এই টার্মটা লাগবে, and if you can explain how that is happening, then you will be getting a full marks. Denervation hypersensitivity. What is that? The name suggests denervation means nerve is cut. Denervation means that. Hypersensitivity means nerve is cut, but the end organ is hypersensitive to the neurotransmitters. So any nerve supplying any end organ, nerve end organ ki hote pare? Glands hote pare, muscle hote pare, kono tissue hote pare, whatever. Blood vessel hote pare. So any nerve supplying to any end organ, if that is cut, there are two compensatory changes. First of all, first jeta hoy, nerve ending theke ki beroy? Nerve works through neurotransmitters. So first of all, and neurotransmitter acts kothaye kaj korche? They act on receptor. These are the two things. So whenever denervation happens, what is denervation? Nerve to end organ, যেখানে নার্ভ থেকে বের হচ্ছে neurotransmitter which acts on receptor who are present on the end organ. Now denervation means this is cut. Whenever this happens, two things happen. First of all, number of receptor goes up. This is known as upregulation of receptor. Upregulation, this is the primary compensation to whatever insult has happened to the nerve. It's a physiological compensation. So first, upregulation of receptor. Upregulation of receptor means number of receptors which are expressed সেটা বেড়ে যায়, সেটার সংখ্যাটা বেড়ে যায়। ফলে নার্ভ কাট হলে whatever neurotransmitter is still coming to that organ, they are still able to function. That is one reason. Second, sensitivity of receptor. Sensitivity of receptor to that particular neurotransmitter increases. These are the primary compensatory response to any kind of nerve injury. This is known as denervation hypersensitivity. এই জিনিসটা after a few weeks it comes down. কিছু সপ্তাহ পরে দেখা যাচ্ছে এটা আর হয় না। And this has been found in experimental animal where a denervation by cutting the nerve is induced. Cauda tympani nerve-টাকে কাটলো, কাটার পর দেখা যাচ্ছে initial few weeks saliva secretion টা বাড়ছে, then that saliva secretion is in plateau phase, and after 7 to 8 weeks it starts going down. So initial part the salivary secretion is up. Clear everybody? Denervation hypersensitivity, it is the cause. Second question. Second part মানে denervation hypersensitivity. Two things are happening. One is number of receptors are increased and sensitivity of receptor to the neurotransmitter is increased. So এই জিনিসটাকে বলা হয় up regulation. The opposite thing is down regulation. বহুদিন ধরে যদি একটা ওষুধ খাও তার এফেক্টটা কমতে থাকে, that is down regulation. For a long time if you are exposed to a particular chemical, receptor number goes down. তো অনেক দিন পরে সেই জিনিসটা আর কাজ করে না। যে কোনো জিনিস any stimulation সেটা যদি বহুদিন ধরে একই stimulation থাকে it comes down. If you give a gap again it goes up. So this is up regulation and down regulation. Any stimulation, any chemical response in our body, that's the physiological way to deal with boredom. You can say like that. Clear everybody? Okay, next one, এটা লিখছি না, এটা নিজেরা লিখে নেবে. Why food is not going into trachea during swallowing, or during swallowing why food doesn't go into trachea? বোঝা গেল? খাবারটা যখন খাচ্ছি ফুডটা খাবারের পার্টটা কেন ট্রেকিয়াতে ঢুকে যাচ্ছে না? This is second question. Why food doesn't go into trachea during swallowing? তাও যদি বুঝতে অসুবিধা হয় during. So explain why during swallowing food doesn't go into trachea. যেতে পারে, গেলেই কি হয়? There is violent response, cough response. একদম চলে গেলে অ্যাসপিরেশন, আর গেলেই there is a violent cough response. কিন্তু সেটা তো অ্যাক্সিডেন্টাল, প্রতি মোমেন্টে তো আর দিস ইজ নট হ্যাপেনিং। কারেক্ট? আমরা যে এই সকালবেলা যারা ব্রেকফাস্ট করে এসছো ফুড তো ট্রেকিয়াতে যায়নি, গেলে there is a severe cough response, সেটা একটা সেপারেট জিনিস। কেন হচ্ছে না? Answer is correct. Epiglottis is usually upright. Whenever I am talking it is upright, but whenever I am eating something that falls backwards and covers up the posterior part of the laryngeal inlet. হ্যাঁ, তো ল্যারিংসের যে মুখটা রয়েছে ওই জায়গাটাকে বন্ধ করে দিচ্ছে। এপিগ্লটিস সোজা আছে, যখনই আমি খাচ্ছি এটা পিছনের দিকে গিয়ে ইট ইজ ক্লোজিং ইট ডাউন। সো যাদের জানার, just epiglottis falls backward and covers up the tracheal inlet. Epiglottis falls backward during swallowing and covers up the inlet into the windpipe. এই জাস্ট এটা কি ঘুরিয়ে ফিরিয়ে লেখা। জোলিঙ্গার এলিসন সিনড্রোম, শর্ট নোট। কোনো আইডিয়া আছে? কজনের আইডিয়া আছে? একটা ট্রাইমেস্টার হয়ে গেছে, কজনের আইডিয়া আছে এটা? There will be increase in secretion of gastrin. যদি সেটা হয়, what will happen? Increase in gastrin means increase in HCl secretion. Excessive HCl secretion leads to excessive ulceration. So the patient will be having multiple ulceration throughout the GI tract. Duodenal ulcer থাকতে পারে, intestinal ulcer থাকতে পারে, gastric ulcer থাকতে পারে, multiple places in over there because it is very harmful in excessive quantity. So basically Zollinger-Ellison syndrome is a gastrinoma. It's a condition which is known as gastrinoma, which is nothing but a G-cell tumor. G-cell tumor that leads to excessive secretion of gastrin, and so much secretion of gastrin will lead to so much high secretion of hydrochloric acid that will lead to multiple ulceration throughout the GI tract. That's it. তোমাদের জন্য এটুকু যথেষ্ট। এর সাথে গ্যাস্ট্রিন সেটা সম্পর্কে যদি দু চারটে লাইন লিখে দিতে পারো that is sufficient. Clear everybody? Zollinger-Ellison syndrome, important short note, very important short note. Next one যেটা করাচ্ছি, that is quite difficult to understand and it is an intermediary concept between GI system and endocrine. Intermediary concept. বইতে ডাইরেক্টলি পাবে না, তো কোশ্চেনটা আসতেও পারে নাও পারে এখন। Pre-PG level you will definitely face this kind of questions, and day in and day out during practice, specifically seeing diabetic patient or about diabetic pharmacology, diabetology যে pharmacology, diabetes related pharmacology, this idea is very important যেটা করাতে চলেছি। তো তার আগে কয়েকটা জিনিস একটু বুঝতে হবে। যেটা করাতে চলেছি এটার নাম হচ্ছে Incretine Effect. Incretine Effect কেউ শুনেছো Incretine? এবারে আর কেউই হাত তুলছে না, যে হাত তুলবে তাকে তো বলতে হবে, আবার একটা ট্রান্সলেটরও জোগাড় করতে হবে। অনেক পিছনে থাকলে দুটো ট্রান্সলেটর জোগাড় করতে হতে পারে, who knows? Anyway, any idea? আমি একটা স্লাইড দেখিয়েছিলাম, তাতে এগুলো সব ছিল। স্লাইডের রেফারেন্স দিচ্ছি হচ্ছে গ্যাস জিআই হরমোনস, তার মধ্যে এটা ছিল গ্যাস্ট্রিক ইনহিবিটরি পেপটাইড, জিএলপি, গ্লুকাগন লিঙ্কড পেপটাইড, ঠিক আছে, গ্লুকাগন লিঙ্কড পেপটাইড or glucagon like peptide, এগুলোকে ইনসুলিনোট্রপিক হরমোনও বলা হয়ে থাকে। গ্লুকাগন রিলেটেড ইনসুলিনোট্রপিক or গ্যাস্ট্রিক ইনসুলিনোট্রপিক হরমোনও এগুলোকে বলা হয়ে থাকে। কামিং টু দ্য ফাংশন অফ দেম, কি ব্যাপার এগুলো? সো হোয়াট ইজ ইনক্রেটিন এফেক্ট অ্যাকচুয়ালি? এইটার নাম গ্যাস্ট্রিন ইনহিবিটরি পেপটাইড or গ্যাস্ট্রিক ইনহিবিটরি পেপটাইড কেন হলো? ফার্স্ট অফ অল আমাদের এটা জানতে হবে। This is gastric inhibitory peptide because when this was discovered, it was seen that at a very high dose, GIP inhibits gastrin release at a very high dose, and that definitely leads to reduction in HCl production. তাহলে কি হচ্ছে, GIP যখন আবিষ্কার হয়েছিল, very high dose GIP inhibits gastrin, and subsequently, as you know, that will lead to inhibition of HCl secretion. Overall this will happen, and ultimately digestion, absorption, everything will come to a standstill যদি if we give it in a supraphysiological dose. However, in normal পরবর্তীকালে দেখা গেছে, subsequently we have discovered that GIP action on gastrin is negligible at physiological dose. তাহলে বডিতে যা জিআইপি তৈরি হচ্ছে ওটা গ্যাস্ট্রিনের উপরে সেভাবে ফাংশন করছে না। তাহলে এ কি করছে? বেসিক্যালি জিআইপি এবং এই গ্রুপের যে হরমোনগুলো রয়েছে, they do what one thing. First of all, they increase insulin secretion from islets of Langerhans. So they increase insulin secretion from islets of Langerhans, যেটা pancreatic beta cell এ রয়েছে, that is one. Second, some of them and most of them have a variable response on glucagon, but mostly their effect is inhibitory to glucagon. So they reduce glucagon secretion. তাহলে if we get a hormone which increases insulin secretion and reduces glucagon secretion, what will be the net effect? Sugar কি হবে? Sugar will go down basically. তাহলে এখানে যেটা দাঁড়াচ্ছে, these hormones are secreted whenever our GI tract is exposed to carbohydrate and fats. So whenever we are taking carbohydrates and fat, GIP, GLP1, they are secreted. The moment they are secreted, they will increase the insulin level. They will reduce the glucagon level. And to some extent, they will reduce the time of gastric emptying. তিনটে যদি একসাথে করি, that will stabilize the sugar level. Clear everybody? মিষ্টি খেলাম, মিষ্টি খাওয়ার পরেই সাথে সাথে যখনই মিষ্টিটা পেটে যাচ্ছে, স্টমাকে যাচ্ছে, সিগন্যালিং হচ্ছে, and these things are coming out. Usually K cells থেকে বা অন্যান্য অনেকগুলো সেল আছে যেগুলো থেকে এগুলো বের হয়। So the moment they are coming out, what is happening? Insulin secretion increases because they are insulinotropic factors. Insulin secretion increases, glucagon secretion decreases, gastric emptying prolongs. Gastric emptying যদি quick হয়, তো quickly intestine চলে যাবে. The quicker it goes to intestine, the quicker it gets absorbed. The quicker it gets absorbed, the quicker sugar level goes high. Carbohydrate absorption, if I can slow it down, sugar level will not go high that much. Clear everybody? Similarly, if I can increase insulin, definitely sugar level will be brought down. If I can reduce glucagon, sugar level will be brought down. Clear everybody? Clear প্রত্যেকে হয়ে গেল? So these effect, overall this effect is known as incretin effect. একদম ছোট করে বলছি, what are incretins? Incretins are group of hormones যার মধ্যে we have GIP, GLP1 এবং আরো অনেকগুলো আছে, but these two are most important pharmacologically active molecules, regular use হয়। আসছে কিভাবে ইউজ হয় তাতে? What they do? What কি করছে? Oral glucose যেই মোমেন্টে ঢুকছে, they are increasing insulin secretion, they are reducing glucagon secretion, and they are prolonging gas or slowing down gastric emptying. So overall effects of incretin is stabilization of sugar level or stabilization of blood sugar. Stabilization of blood sugar. So this is incretin effect. From here, etake likhe nao. From here, two more explain why questions can be asked. First of all, insulin secretion is increased more in response to oral glucose challenge rather than IV glucose challenge. Clear? কি জিনিস হচ্ছে? ওরাল গ্লুকোজ, তুমি মুখে গ্লুকোজ খেলে সেম অ্যামাউন্টের গ্লুকোজ diluted form, same dilution, if you give on IV, intravenous, insulin secretion বাড়বে ওরাল গ্লুকোজের পর, IV গ্লুকোজে অতটা বাড়বে না। ক্লিয়ার হলো? তাহলে গ্লুকোজ যদি মুখে নি, ইনসুলিন সিক্রিশন উইল গো হাই। গ্লুকোজ যদি সেম অ্যামাউন্টের গ্লুকোজ IV নি, ইনসুলিন সিক্রিশন স্টিল উইল গো আপ, বাট নট দ্যাট মাচ। The reason, the explanation is incretin effect. ওরাল গ্লুকোজ থাকলে কি, কারণ কি যখনই আমি এখানে গ্লুকোজ নিচ্ছি, দ্য মোমেন্ট গ্লুকোজ গোজ আপ, আইলেটস এন্ড ল্যাঙ্গারহ্যান্স সেখানে বিটা সেল ফাংশনালি অ্যাক্টিভ হয়ে উঠবে, সবকিছু হবে, কিন্তু ইনক্রেটিন এফেক্টটা থাকবে না। ইনক্রেটিন এফেক্ট সবসময় ইন্ট্রাজিআই ফুড গেলে সেখান থেকে ইনক্রেটিন এফেক্টটা আসছে, এন্ড দ্যাট ইনক্রিজেস ইনসুলিন লেভেল। সো IV গ্লুকোজ চ্যালেঞ্জ ignites insulin response, oral glucose challenge also ignites insulin response, but oral glucose channel does it more with respect to IV glucose challenge. Clear everybody? এইটা একটা ভীষণ ইম্পর্টেন্ট, মাল্টিপল টাইমস কোশ্চেনটা এসছে যে ওরাল গ্লুকোজ ইনক্রিজেস মোর, oral glucose increases insulin secretion more compared to IV glucose. Clear everybody? বোঝা হয়ে গেল? This is incretin effect হচ্ছে তার রিজন। সেকেন্ড, এটা একটু হাই লেভেলের হয়ে যাবে, বাট স্টিল সিন্স in continuation I do believe that you will understand. যে do we use this GLP1 and GIP in day to day practice? Yes, we do. তার আগে একটা জিনিস বুঝতে হবে যে GLP1 and GIP, these incretins, there is an enzyme which is known as DPP4. This enzyme breaks down GLP1 and GIP. What is the function of GLP1 and GIP? Reduction in blood sugar. Clear everybody? এখন অবধি ক্লিয়ার? তাহলে যদি DPP4 এই এনজাইমটা কাজ করে, what will happen to blood sugar? It will go up. এটা টোটাল জিনিসটা, এটা তোমাদের জন্য মোর দ্যান সাফিসিয়েন্ট রিগার্ডিং দিস এট দিস পয়েন্ট। তাহলে আমরা এখন অবধি কি পেয়েছি? GLP1, GIP, these are incretins which stabilizes blood glucose, which are secreted whenever we are taking food. Clear? Now if we have good amount of GLP and good amount of GIP1 in our body in activated form, then blood sugar will always be normal. Clear? But the T-half of GIP and GLP1 is not that high, because there is someone who quite quickly breaks them down. তার রিজনটা কি সেটাও বডি এই কারণে দিয়ে রেখেছে, বিকজ ইফ দিস ইজ সো প্রলং, ইফ দ্য অ্যাকশন অফ জিআইপি এন্ড জিএলপি ইজ ভেরি প্রলং, হোয়াট উইল হ্যাপেন, আমাদেরকে গরুর মতো সারাদিন খেয়ে যেতে হবে, তাই না? আদারওয়াইজ হোয়াট উইল হ্যাপেন, সুগার উইল ফল ডাউন, তুমি খেয়ে যাচ্ছ সুগার কমে যাচ্ছে, যত খাচ্ছ সুগার কমে যাচ্ছে, দ্যাট উইল বি আ ভেরি ইউনিক কন্ডিশন, বাট দ্যাট ডাজন্ট হ্যাপেন বিকজ ওরা কি করছে, ইনিশিয়াল লোডটাকে অফ করে দিচ্ছে। অনেকটা তুমি মিষ্টি খেলে তাও দেখা যাবে ইন নর্মাল পেশেন্ট, তুমি যদি এখন 15টা রসগোল্লাও খাও, your sugar will not go that high. আমরা যদি 15টা রসগোল্লা খাই, যারা নর্মাল আছি, যারা নন ডায়াবেটিক, তাদের কি 600 সুগার হয়? হয় না। Somebody is blocking that. Who is blocking that? Many factors are there, but this is also a very important factor. Postprandial সুগারটা রাইজটাকে আটকে দিচ্ছে to some extent. কিন্তু এটা যদি অনেকক্ষণ ধরে করতেই থাকে, পোস্টপ্রান্ডিয়াল সুগার রাইজটাকে যদি অনেকক্ষণ ধরে আটকাতেই থাকে, তাহলে কি হবে? তাহলে সুগার কখনোই উঠবে না। সেই জন্য বডি হ্যাজ মেড সাম ইউনিক অ্যাডভান্টেজ, কিছু এনজাইম এরকম দিয়েছে হু উইল ব্রেক দেম ডাউন। DPP4 is such an enzyme who will break them down, so sugar again goes up, whatever is the body's need. এইখানে দুটো ফ্যাক্টর কাজ করছে, এইখানে দুটো ফ্যাক্টর কাজ করছে। One factor is if we use something called DPP4 inhibitor, if we use something that is known as DPP4 inhibitor, তার ফাংশনটা কি হবে? GIP কে it will stabilize, so that means GIP level will be high, that means sugar level will be low. So there is a scope that DPP4 inhibitor kind of molecule we can use in treatment of diabetes. We do use sitagliptin, linagliptin, খুব কমন, জ্যানোভিয়া বা এই টাইপের কয়েকটা মেডিকেশন আছে। যাদের বাড়িতে পেশেন্ট আছে দেখবে কি ওষুধ খাচ্ছেন, that's very commonly prescribed nowadays, sitagliptin, linagliptin, vildagliptin. These gliptins are actually DPP4 inhibitors. এটা তোমাদের পরের বছরের কোশ্চেন, কিন্তু এবছরের কোশ্চেন হিসেবে দেওয়া যেতেই পারে যে DPP4 inhibitors can be used in treatment of diabetes. Explain why? দেওয়া যেতে পারে, দেওয়াই যেতে পারে, তোমার নাম জানার দরকার নেই, you need not know the name of the DPP4 inhibitors, but how they work you should know. So DPP4 inhibitors, they prevent the blunting of incretin effects. They prevent the blunting of incretin effects by keeping the GLP and GIP, stable in the environment, intestinal environment. Clear everybody? তাহলে incretin effect, আবার বলছি কমপ্লিকেটেড জায়গা। GIP, GLP1 এরা প্রথমে অন্যভাবে আবিষ্কার হয়েছিল। ইনিশিয়ালি দেখা গেছিল these are gastric inhibitory molecules, কারণ কি করছে এরা physiological or supraphysiological level they are slowing down gastric emptying, but only in supraphysiological level they can reduce the HCl production. Later we saw that more than exocrine, they have more endocrine property in the physiological zone. And in the physiological zone, in the normal range, what they do, they blunts the effect of high carbohydrate load. How they do this? Whenever high level of carbohydrate reaches intestine, immediately they increases the secretion of insulin, reduces the secretion of glucagon, and slows down the gastric emptying, leading to slower absorption, and whatever is being absorbed, still insulin is breaking it down, or still insulin is bringing it down basically. But the problem is they are not a very stable molecule. Very quickly DPP4 dipeptidyl transferase, but you can forget it. DPP4 molecule is an enzyme which breaks it down, and again sugar may go up. So in diabetes treatment we can use DPP4 inhibitor which will maintain them. আরেকটা অ্যাকশন রয়েছে GLP1 by injection or by oral. There has been oral preparation also. GLP1 itself is used as a medicine in diabetes, as a medicine in diabetes. GLP1 এটা প্রথমে ইনজেক্টেবল ফর্মে এসেছিল, নাও we also have the oral form of GLP1 analogs. Analogs means same kind of molecules or molecules having the same pharmacological property. So এখান থেকে দুটো জিনিস জানা গেল, GLP1 কে আমরা ইউজ করতে পারি as a medicine for diabetes, অথবা some molecule which prevents the breakdown of GLP1 and GIP, we can also use them and as the medicine of diabetes. Clear everybody? An incretin effect can come as a short note. এই পরেরটা DPP4 টা it will only come if the question is very difficult, otherwise তাও আমি বলে রাখলাম, but incretin effect has appeared multiple times in the examination. পরের কোশ্চেনটা ইজি, আগে বলেছি, জাস্ট উইল গো থ্রু। হোয়াই স্টমাক ইজ নট অটো ডাইজেস্টেড? গ্যাস্ট্রিক মিউকোসাল ব্যারিয়ার। হোয়াট এলস? যেগুলো ইজি কোশ্চেন হবে তাতে একটা পয়েন্ট লিখলে হবে না, I have to answer a multiple, I mean all the points you need to cover. So bicarbonate, mucin, anything else? Why stomach is not auto digested? First of all, কি cause আছে? এক হচ্ছে gastric mucosal barrier. Now gastric mucosal barrier, it is made up of mucin. It's a layer of mucin and bicarbonate. Where are they? Suppose these are the epithelial cell. These are the epithelial cell. This is the mucosal barrier. Lot of mucin and bicarbonate molecules are there. Then this is the lumen. So if you look at the pH level, definitely these cells are close to 7.4. This area pH is 7 and this area the pH is 1.5 to 2.5. This is only possible because of this mucosal barrier. This is one understanding. Second understanding is there is tight junction. So this is a tight junction. So whatever acid is being formed, this acid is not being leaked through the tight junction. It can only go that side, it cannot go in between. That's the second reason, tight junction. Third reason is trefoil peptides. Trefoil peptides. What are these? Trefoil peptides are actually acid resistant peptides. So acid resistant peptides, these are also present in the epithelial border, which is helping it resisting the low pH. So এই তিন চারটে কজ, আরো একটা কারণ আছে, that is prostaglandin. The fourth cause is prostaglandin. Prostaglandin. And prostaglandin helps in secretion of mucin. লিখে নিতে পারো। Prostaglandin helps in secretion of mucin.